Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello everyone and welcome to episode number 90 of the Better Health Guy blogcast series. Today's guest is Dr. Kent Holtorf, and the topic of the show is peptide therapy. Dr. Kent Holtorf is medical director of the Holtorf Medical Group. He is founder and director of the nonprofit National Academy of Hypothyroidism, which is dedicated to dissemination of new information to doctors and patients on the diagnosis and treatment of hypothyroidism. He has personally trained numerous physicians across the country in the use of bioidentical hormones, hypothyroidism, complex endocrine dysfunction, and innovative treatments of chronic fatigue syndrome, fibromyalgia, and chronic infectious diseases, including Lyme disease. He is a fellowship lecturer for the American Board of Anti-Aging Medicine, the Endocrinology Expert for AOL Health, and is guest editor and peer reviewer for a number of medical journals. Dr. Holtorf has published a number of peer-reviewed endocrine reviews, including on the safety and efficacy of bioidentical hormones, inaccuracies of standard thyroid testing, testosterone replacement for men and women, the diagnosis and treatment of growth hormone deficiency, and on the diagnosis and treatment of adrenal dysfunction in chronic fatigue syndrome and fibromyalgia. He has helped to demonstrate that much of the long-held dogma in endocrinology is inaccurate. He is a contributing author to Denis Wilson's evidence-based approach to restoring thyroid health. He has been featured on CNBC, ABC News, CNN, Extra TV, Discovery Health, The Learning Channel, The Today Show, Dr. Dean Edell, Glenn Beck, Nancy Grace, Sean Hannity, and more, and quoted in numerous print media including the Wall Street Journal, Los Angeles Times, U.S. News and World Report, San Francisco Chronicle, WebMD, Elle, Better Homes and Gardens, U.S. Weekly, Forbes, Cosmopolitan, and Self Magazine, among many others. And now my interview with Dr. Kent Holtorf. It is an honor for me today to have Dr. Kent Holtorf on the show to talk with us about peptides. Thanks so much for being here, Dr. Holtorf.
Oh, thank you for having me.
Thanks. I know that you do the work you do today because you had your own personal experience with chronic health challenges, including Lyme disease. So I'm wondering if you can tell us a little bit about your story and how your own personal journey led you to the passion that you have today, helping so many other people dealing with chronic illness.
Yeah, and it's not dissimilar to, I think, a lot of people in this arena. They've had loved ones or themselves go through it. And, basically growing up, normal, great childhood, but had weird things going on. Like one had anisocoria, one pupil bigger than the other. All of a sudden I would just get like arm weakness, weird Raynaud's, basically autoimmune stuff come and go. So it was strange, but it wasn't like, oh my gosh, it was very functional. Then went on to college, things did okay, started getting more tired, couldn't get up, terrible temperature tolerance. The big joke was I have a 2-degree temperature tolerance. If it's hot, just pouring sweat, night sweats. And then went on to medical school and just that's when it really started progressing. I'm like, something's wrong. Like I can't function. I'm just so tired. I'm achy, brain fog, and like, oh, you're distressed. Here's an antidepressant. I'm like, I'm not depressed. I'm like, I can't function. And just talking to a patient was so overwhelming. But I figured out what the heck can I do? So I went into anesthesia because you don't have to talk to them because they're asleep, right? But went into that, and I could function, but that is no disrespect to anesthesiologists, but it is the most mindless specialty ever. So I get anyways. But so then I started going on. Was very evidence-based, and I'm still very evidence-based, and it's really ingrained in you in medical school and residency to don't seek anything alternative. Alternative means basically no evidence, right? So I'm like, I got to do something because I'm dying here, and could never sleep, and just you get anxiety and panic attacks. And so I started going to some so-called alternative conferences, and I went and I'm like, damn, these are more evidence-based than what they're teaching me in residency. And just got really excited about that and took a lot of therapies home and helped myself. I'm like, I'm a new person. I go, this is great. And so from there, I said, anesthesia is not for me. So then went into family practice, opened a family practice, and then concentrated on the patients that were like me, and the ones that just don't fit in any box, and we found a lot of thyroid patients, and it was early on with like chronic fatigue syndrome, fibromyalgia. And it's interesting, my dad, he really had chronic fatigue syndrome before that was even ever heard of. But, and then so started progressing more, and then learning more. We opened 22 centers across the country, fibromyalgia fatigue centers. Then started doing franchises. And then what happened was, we find emotional stress is just a killer for this illness, and which is unfortunate because that's why a lot of doctors go, oh, it's just a stressed out woman. You're going through this, a loss of a pet, or divorce. But divorce is very stressful. All of a sudden, I could not get out of bed. I was hit by a truck, night sweats, just terrible neuropathy, and just could not function. And then so basically started going around the world to try to find treatments to help me. I knew I had Lyme. That's what we treated, but my blood was so thick you couldn't draw it out at all. And so ended up with Babesia and Bartonella. Babesia really huge in that coagulation. And so basically just found all these treatments that could potentially work, and brought them back to patients, and a lot of great treatments. And actually even kind of early on, I was using peptides. I was flying to Switzerland and Belgium and other places to get peptides for myself. Couldn't use them on patients, but found that I had basically 3.5 years of the highest dose antibiotics that I would never give a patient, right? And 2 weeks later, I could be back to where I was, if not worse. So there seemed to really need a different way. And that's where we started looking at, the immune system, immune modulators. And, it's really a multi-system problem where one thing affects another. And so you can't say, well, what's the cause? Over the years, it's like chicken or the egg. It kind of doesn't matter. But then when I really started to focus on peptides and also stem cells, that really brought me out of the fog and felt
wow.
good.
So let's start then with kind of a high level for people listening. What are peptides? How are they similar to or different from amino acids, from proteins, maybe from hormones? Are they available today? Is it something that we can get? And if so, why aren't they better known? Why aren't more practitioners using them in practice?
Yeah, I'll answer the last question. Like, how come my doctor doesn't know this? And I give talks around the country to doctors and do these, PowerPoint presentation with hundreds of references. And just unbelievable. And everyone says, why haven't I heard of this before? So it's interesting because they're not patentable. So there's no drug company going to do it. And so it hasn't caught on. But peptides, yeah. Peptides is kind of an arbitrary term. So peptides are a link of amino acids. And basically you'll see different definitions, but generally 50 and below is a peptide. Over that, it's a protein. So just think of a peptide as a small protein. Now, we didn't know much about them. Everything was hormones. That's what controls everything. But we're finding the peptides actually are the master controllers, and they're working at really the cellular level. And the difference between the hormones tend to be basically long on for effect and long off. So they kind of work like this. Peptides tend to be more specific, and quicker on, quicker off, and exceedingly safe. And you look at majority of these peptides, I mean, they give, rats hundreds or 1,000 times a dose, and they can't find a toxic level. For instance, like BPC, they can't find it. So they're very safe, and they just can do so many things. And we're learning more and more peptides. There's so many peptides in the body where, I would say we probably know about 10% of them.
Wow.
And the ones that happen to be studied, those are the ones we use and have the research behind.
Well, how are peptides created? Are these naturally occurring? Are they synthetically created in a lab environment? Where do they come from when we're taking them exogenously?
Yeah, so you don't want people to say, hey, are they natural? I like to use bioidentical because, let's say, like growth hormone. You can get natural growth hormone from the pituitary of a bunch of people, and that's when all the problems with the prions and things like that. Well, you can't give blood if you get growth hormone, but now that's genetically made. So now they actually have peptide synthesizers where it's much more complex than this, but you dial up basically the peptide you want, and it takes the amino acids and makes them. And so
do peptides have a place both in acute conditions and chronic conditions? What are some of the key conditions where you've clinically used peptides in your practice, and to what extent do people see symptoms improving in your patient population?
Well, it's just, again, it's changed our practice focus. And we generally have ended up being, basically the last stop. We did a study on patients. They saw an average 7.2 physicians before seeing us. That was 15 years ago. And 85% got significant visit by the fourth visit. But now it's, the stories where they just go doctor to doctor, because now doctors compartmentalize everything. Oh, the neurologist says this, gastroenterologist says this, and infectious disease says this, and no one puts it together. And they just, if a doctor can't treat it, it doesn't exist. And I'm kind of disgusted with the medical community on how rude and that they can be to these patients and just dismiss them, make jokes about them. And we found that the less a doctor knows, the more adamant they're right. And so when it was kind of freaked me out the first 10, 15 years ago, we'd have a patient been sick for 10 years, go back to their either primary or specialist, better, and they're excited to tell their doctor. I thought they'd be happy. They're not. They're like, oh, whatever it was quackery. Well, don't you want to hear what it is? No, I don't need to know that. And so it's really interesting.
Yeah, I think back to your earlier comment about the mental, emotional stress aspect of these conditions. I think if we didn't have some mental, emotional stress contributor to maybe setting the stage for a condition, going through something like chronic fatigue syndrome, Lyme, whatnot, creates its own emotional trauma for many people, right? The invalidation that then you have to also address that component in order to move through the illness itself.
Yeah, it's a very complex condition. And our system is not set up for complex conditions. If you don't fit into a little box, you're going to get terrible care, and doctors are generally the 15-minute visit. Oh, this is what you got. Here, take this, go. They don't, hey, that's not my area. That's not my area. So it's tough.
What are some of the conditions where you're finding peptides helpful, like Lyme, autism, chronic fatigue, fibromyalgia, all of those?
All the above. And the problem with the peptides, especially like even just look at one peptide, BPC, is it heals almost everything. So it's everything from brain to gut to to the Achilles tendons, muscles, regenerates liver, lowers inflammation. I mean, that's just one. So really, and neurodegenerative diseases, traumatic brain injury. In fact, 3 days ago, our accountant had a terrible pain in the bottom of his foot, and he basically had an inflammation of his sesamoid bone. And they tried a steroid shot, and then he took a couple of BPC capsules, and he's like, "This is weird. It doesn't hurt anymore." So,
wow.
Yeah, I mean, and that doesn't work for everyone, but it's one of the things we found that also, again, antibiotics have their place, especially for Lyme, but we found if you don't, get the immune system working, you'll never get rid of it.
So for people that are hearing us talking about peptides and wondering where do these normally come from, is it true that most or all of the peptides that we might now be able to exogenously introduce or introduce from outside the body, that those also exist in the body, or is that not always the case?
Yes, most do exist in the body, or they're a little modified for stability or delivery.
So something like BPC 157, which we're going to talk more about, though, that is something that we do have in the body normally, correct?
Absolutely. Yeah, it's with tremendous amounts in the stomach. It's very stable, and it's a fragment of the parent compound. So we're finding fragments often work as well as the whole compound, if not better.
What are some of the different categories of these peptides that are available now for clinical use?
Yeah, so if you look, and let's say we were to break them down, I'd say immune modulators, which are, would consider the thymosins. So the thymosins are basically different peptides, from the thymus gland, which is here in your breastbone, and they produce a number of different thymic peptides that modulate. So if you look at the immune system, one side's Th1, this gets stuff inside the cell. Th2 gets stuff outside the cell. Now, normally they're balanced. We find with any chronic illness, stress, inflammation, autoimmunity, and everything's a cause and effect, is that Th1's too low, so you can't fight intercellular infections, and Th2 is too high, so you get all this inflammation and risk for autoimmune disease. And when you get the Borrelia in the blood, it starts secreting substance to basically reduce Th1, the intercellular, and then it goes inside the cell. Now you have chronic Lyme, and that can actually occur very quickly. People say, it takes, a number of weeks, but it can happen much faster than that. And you look at, the standard treatment, even if, if you catch it early, it's curable. They found that patients with proven acute Lyme caught early with the standard Infectious Disease Society protocol relapse, 70% of them relapsed, with the illness. So it was not cured.
So when we have this Th2 dominance, essentially we become accumulators of these intracellular infections, right? We're not able to address the infections inside the cells, and that then perpetuates the whole condition.
Exactly, and that drives it more, and this causes autoimmunity, mast cell activation syndrome, and just general inflammation, brain fog, just that flu-like feeling.
We know that many of the diseases of aging, even outside of some of these chronic conditions, are immune dysfunction or senescence as well as inflammation. So from your perspective, what are some of the key factors that lead to aging in the body that we potentially can address or support with peptide therapies?
Yeah, so if you look at, the thymus, it basically involutes right about age 30 and as it goes. And that's when all the disease of aging start occurring, and they're really all partially due to low immune system, to rather a dysfunctional immune system. The CDC said 80% of age-related diseases are from thymic dysfunction, and many people, they also have a pineal gland dysfunction. When they get calcified, it gets old. And one of the peptides we like a lot, probably the biggest anti-aging peptide, is epithallium, and it's shown to increase telomeres. So, telomeres are basically, every time the cell replicates, the telomeres shrink. So the cell's going to go through so many different replications, but it lengthens those, so it's basically an anti-aging hormone. And especially when you combine it with the thymosins, some amazing studies showing that human studies, people over 65 with significant cardiovascular disease live much longer. They actually improve their cardiovascular effect, their cardiovascular function, less cancer. So, the ultimate anti-aging stuff, I think, is with these peptides.
So many people say that aging is tied to chronic inflammation, but what I'm hearing is it's really more dysregulation of the immune system that leads to inflammation, and that combination that actually is what causes aging in part, and that the focus on fixing the immune system then, or modulating the immune system, is one anti-aging strategy, correct?
Right. And you look at, a lot of the mast cell activation syndrome guys,
Yeah.
they are brilliant and very true, everything they say, but they really focus on how do you directly affect the mast cells. But the key is look upstream and affect the immune system that's affecting the mast cells. And we get much, much better results and have good luck with those patients that are sensitive to everything, just have a multi-system problems. But they go, I can't tolerate that.
Is the mast cell activation then tied to the Th2 upregulation?
Absolutely, yes.
Okay. Yeah. Let's talk a little about hormone therapies and peptides. So oftentimes as people are aging, they reach for hormone therapies. Are peptides an alternative to hormone therapies? Is it the peptide that then is signaling the body to produce more hormone, or is it similar to exogenous supplementation of these different hormones?
Yeah, I would say they're adjuncts. They work very synergistically. And I just actually last night was reading a paper on how younger women now are so scared to do hormone replacement therapy, because the Women's Health Initiative study, which we can go on for hours about that, when you give oral synthetic estrogen and progestin, it causes breast cancer and heart attacks. No doubt about it. But if you use transdermal estrogen and natural progesterone prevents breast cancer. If you want to give someone breast cancer, give them progesterone. You want to prevent it, give them progesterone. Transdermal estrogen, no association with increased clotting, actually trend for less heart disease. Actually, a good trend for less heart disease with the combination.
Many times people with chronic illnesses like Lyme and fibromyalgia, chronic fatigue, are introducing thyroid, maybe testosterone, estrogen, progesterone, maybe even growth hormone, a lot of these different hormone therapies to support their system. So my initial question was, can those potentially be replaced by peptides, or are there some of them that we still need to supplement separately, like thyroid, for example? And it sounds like what you're saying is they really are synergistic, and we may need to do a little bit of both.
Yeah, growth hormone is a peptide. And now we got growth hormone releasing peptide, growth hormone releasing hormone that we give, which can stimulate your body's own production of growth hormone. But in terms of, there's certainly peptides that can stimulate estrogen, progesterone, but we're not to the point where that it can be done consistently, what dose. So it's much cheaper and much easier to just give, again, estrogen, progesterone. Now thyroid, almost every Lyme patient is low thyroid. Despite what your doctor says, the normal TSH, and I give lectures on this and show doctors at our nonprofit, the National Academy of Hypothyroidism, hypothyroidism.org, a bunch of review papers, hundreds of references, shows that the way that we're diagnosing and treating thyroid in this country is terrible. And this is especially true if anyone has any chronic illness, depression, inflammation, and or even aging. So it's, looking at the TSH pituitary is like different than every other tissue of the body. And we're looking at that to determine the level of thyroid in the rest of the body. So the quick thing everyone learns in medical school, the endocrinologists learn that, so the pituitary in the brain produces thyroid stimulating hormone, TSH, which tells your thyroid to secrete T4, which then needs to convert to T3. It needs to go into the cell, and then or it can be converted to reverse T3, which blocks the thyroid. Now, when you have all this inflammation, the pituitary sees more T3, the TSH suppresses. And a lot of people will have a high T4, And the doctor goes, oh, you're kind of high thyroid. No, because if there's low cellular energy, the thyroid hormones can't get into the cells. And that's shown to be the rate limiting step. So we look at, different tests. We can pick people out pretty well. You look at sex hormone binding globulin, measures the amount of thyroid and estrogen in the liver, Thyroflex, which measures basically, the British Medical Journal showed that a knowledgeable doctor looking at someone's ankle reflex was a better test than blood tests for thyroid. Like, how could that be? They found a normal reflex goes, but with low thyroid goes, and so we have a computer that measures that. We'll check everyone's basal metabolic rate. A lot of people have trouble losing weight, especially if they fasted a bunch of times, yo-yo dieting. They usually have 25% lower metabolism, about burn 300 to 500 calories less a day. And depression, they all should be on T3. And the studies, I can go through studies on thyroid like crazy. It's just unbelievable that these people are just told, suck it up, exercise more, and it doesn't work.
Coming back to TH1 and TH2 dominance, what are the best ways to test with a lab test to see if you are TH1 or TH2 dominant? I know for a while there were a lot of these cytokine-focused tests that didn't really seem to kind of pan out. So for TH1 and TH2, what do you look at as potential indicators of their levels?
That's an excellent question. And we found it is so difficult to basically process the cytokines in a way that they're going to be accurate. And they're just all over the place, or a lot of them end up all zero. And also it's interesting when you look at research, or this is a TH1 disease, TH2, but you go look downstream too. So TH1 basically cytokine may stimulate TH2. So it's kind of what's the end effect. So what we do look at is so an endpoint is natural killer cell function. So they basically take your natural killer cells, which are the cells in the body that monitor the body for intracellular, for infections and cancer, and those get very dysfunctional with low TH1. And then with TH2, we look at C4A. Although there's problems getting that test, it has to be on dry ice, and people have to know what they're doing. We deal with LabCorp to do a new one. I don't know if it's really working out like we thought. We can also use human transforming growth factor beta, which is another marker that's a big TH2. And you'll see those with treatment. You'll see them go down and come up.
Yeah, it's interesting with C4A. Since LabCorp started doing them on their own, I have not seen an elevated C4A. When I used to go to National Jewish in Denver, I saw lots of C4As that were elevated, but have you seen very many from LabCorp's own processing?
No, and they promised us, because they did a special, we talked to the medical director, he says, okay, we're going to do the same methodology as the Quest.
Okay.
And the Quest is difficult to deal with. We're excited, but yeah, everyone kind of seems to be put in the normal range. The same thing happened with reverse T3. So what you want to know for thyroid, what your free T3 reverse T3 ratio is, and when they use the radio immunoassay, RIA, it had a nice range correlated clinically. Now they're using the GCMS, LCMS, and everyone just crunched in the middle. So it's much less clinically useful. So, it's funny to say, well, this is more precise. Yeah, it's more precisely wrong. So
it sounds like we're talking about the fact that in these chronic conditions, the immune modulation piece is so key to moving people forward, that you need to modulate the immune system so that the body's own immune system can focus on these chronic intracellular infections and shift things back from TH2 dominant to a balance of TH1 and TH2. So let's talk a little about the thymosins. Tell us a little about thymosin alpha 1, thymosin beta 4, what these are doing, and maybe how you determine when one might be more appropriate than the other.
Yeah, those are great questions. And thymosin alpha 1 is probably the most studied. And again, if you look at the two sides of the immune system, thymosin alpha 1 is going to raise that TH1. So it's approved in about 30 other countries or so for everything from cancer, HIV, chronic infections, and shown to boost that. And everything's a teeter-totter. If you raise this, the other side's going to go down. And that's where BPC comes in, lowering the inflammation. But thymosin alpha-1 studies on so many things, on autoimmunity, MS, any chronic infection. And you can't believe the studies. People, like hundreds of studies. So that's kind of our main, I would say the mainstay is the most literature behind it. Excuse me, thymosin beta-2, we'll put thymulin in there, more of a modulator. It has some different effects as well. It also is shown to regenerate heart tissue after MI. It's shown to prevent fibrosis in the liver from drinking. It basically is shown to work for neuropathy, traumatic brain injury. They give and dramatically improves all these conditions. So it's very much a repair hormone.
My perspective for a long time has been when someone has a, quote, autoimmune condition, that there is generally some microbe there that the immune system is doing its best job to protect us from, not that it's just attacking us for no reason. And so we oftentimes use tools that modulate the immune system, try to integrate our microbiome or create tolerance within our microbiome, things like maybe low-dose naltrexone or Plaquenil or low-dose immunotherapy, Ty Vincent's work, homeopathy. It sounds like the peptides present another option for really helping to kind of address that, what people think of as autoimmunity, which really is immune dysregulation with some underlying pathogen trigger. Is that a reason?
Oh, yeah, very, very much so. And there are studies showing that perhaps maybe every autoimmunity is being driven by a low-level chronic infection. And it just drives it. So we'll see people with Hashimoto's, or so many patients with Lyme come in, I got diagnosed with pre-lupus or mixed connective tissue disease, means they go to a rheumatologist. Well, we don't know what it is, but it's autoimmune. Antiphospholipid syndrome, you'll see a lot. And so, yes, modulating that immunity is really the key.
Let's talk about then some of the maybe antimicrobial support options in the peptide therapy realm. So we have the immune modulation. From what you're saying and my understanding, that's really kind of critical first. You don't want to just go after killing bugs without having done some modulating of the immune system. So when we get to the place that we say we've modulated the immune system, but we maybe do need some antimicrobial support in the realm of Borrelia, Bartonella, Babesia, and so on, what are some of the peptide options that can help us there?
Yeah, and just to kind of reiterate, when you look at your immune system, let's say you have a high immune system, you have an infection. All you need, let's say you have a sinus infection, normal person, good immune system. The antibiotics don't kill anything till there's nothing. The immune system has to be there. So let's say here's your immune system. If the infection's under here, now it can take over. And many of these infections we never get rid of. People are like, oh my gosh, you can't believe how many infections we have. Look at, all the Epstein-Barr's. I mean, there's just so many that if your immune system drops, they all just come out. Now, those all also suppress the immune system, becomes a vicious cycle. So, so antibiotics have their place. A lot of people that come to us have been on so many different antibiotics. And so we'll give them a break at their immune. We found if you want to get from point A to point B, you're much better off to get there quicker by fixing the immune system before trying to slam them with every antibiotic. But they do have their place. And then there's the peptide LL37, which is natural in the body. It's also secreted by stem cells, which is interesting. Is one reason why stem cells are very good for chronic infections. And it's basically your body's natural defense. They're defensins, peptides that the nice thing is they're such a wide range of coverage of viruses, bacteria, yeast, parasites. So we're reaching those. There's not a lot of that, but we're using that, we're incorporating that more and more. And I think that sometimes is becoming like, oh my God, nothing, antibiotics weren't working till I added that to it.
And is that LL37, is it helpful for Borrelia, Bartonella, and Babesia, or is it more specific for one or the other?
We don't know, but it seems to have a wide range, so would expect it to. There's not that many studies on it. There's a lot of studies on it, but you're kind of research oriented, and no one, Lyme. Hardly anyone studies Lyme because it doesn't exist. Chronic Lyme, right?
Right.
It's so-called it doesn't exist.
One of the things that was interesting about LL37 to me as I was preparing for our conversation today was I read somewhere that it kills Borrelia cysts better than tinidazole. And I know that tinidazole, from I believe it was some of the research that Eva Shoppe had done at University of New Haven in Connecticut, tinidazole is actually one of the better pharmaceutical medications for dealing with Lyme. And so that's a pretty exciting and compelling statement there, that this potentially works even better than tinidazole.
Yeah. And we have the bar graphs up on talks, and people are like, really? Why haven't I heard of this? And it also lowers human transforming growth factor beta, which is like that Th2. So it works much better in the body than it does in the test tube, because it also has immune modulating factors.
When someone's using LL37, how long might they use it? Like, I know we talk in Lyme with antibiotics. Sometimes people have been on antibiotics for years. And then does it lead to traditional Herxheimer reactions when people incorporate it?
We see much less. And also, when you get the immune system balanced, you find much less Herxheimers, because the Herxheimer is a huge Th2. So if you basically get the immune system at Th2 down, you're going to find much less Herxheimer's. And, I'm always testing on myself. I did a huge dose. I got a Herxheimer on it. But I would never give that dose to anyone else. But so we basically go slow, but we found it can be very effective, and some really exciting research coming out of that.
And what's the potential duration of something like that in a longer term protocol for something like Lyme disease?
Yeah, usually we'll pulse it, we'll use it, we'll take a break, because there's no great long-term studies on it.
Okay. So we talked a little about Herxheimer reactions. I mean, it sounds like many of these, if the Herxheimer reactions are tied into the upregulation or the dominance of Th2, that BPC 157, the thymosins, LL37, it sounds like many of these peptides have the potential to minimize those Herxheimer reactions, right?
Very true. Like, one study looked at that in particular with thymulin, showed dramatic reduction in Herxheimer. Thymosin alpha works, thymosin beta, BPC. So yeah, you have a wide range.
In patients that have been sick for many years with something like Lyme or chronic fatigue, a lot of times they just can't be very active. They lose muscle mass over the course of their illness. And so maybe even having low growth hormone, maybe for other reasons. But can the peptides then be supportive in terms of regaining some of that lost muscle mass?
Absolutely. And so you look at, the growth hormone releasing hormones and peptides, and there's a lot of those. And I do worry that they start getting into the bodybuilding world, because that's not what we're using them for, but, which brings unwanted attention. There's another peptide called follistatin, which basically reduces body fat and increases lean muscle. And again, also lowers human transforming growth factor beta.
Wow.
And that can work very, very well, but it tends to be expensive. So not a lot of people carry it.
CD57 is, at least from my perspective, a somewhat crude marker that's been looked at in Lyme disease for many, many years. I mean, at the beginning, maybe it's useful to say, yes, there's another indicator here that your immune system is suppressed. I haven't seen it generally be all that helpful in terms of tracking progress of treatment. And I haven't always seen it necessarily increase even when people start feeling really good again. But I'm curious, can we see CD57 levels increasing with the incorporation of some of these peptides?
Yeah, those tend to be the last thing to come up. And it matters what lab as well. And it's it's crazy. I did a big panel on one of our employees, and just basic stuff like with Quest and LabCorp. One, his insulin was 4, the other one it was 14. One, his average blood sugar was 5.9, the other one 5.3, and he went from one to the other. Just got his blood drawn, went upstairs to the other place. It's scary, and so you can't hang your hat on any one test. And that's why we do a huge panel to paint a picture. And a lot of times it's like, yep. And people are like, or people will call and say, what if you don't find anything? Well, it hasn't happened yet, coagulation markers are huge. You see with babesia, especially, but can be with anything. And so it's an art still. It's not black and white.
And unfortunately, what I see a lot of times with lab tests, whether it's genetic tests or whether it's CD57, is, it maybe does go down after someone's been treating for a while. They don't understand these variations that you're talking about, maybe even expected variations if the labs are even accurate and consistent. And thus they then lose hope that they're on the right path. And then that ultimately is the thing that probably affects them more than anything, is the fact that now they feel less hope in what they're doing.
Oh, it's totally true. And some people come in and they expect magic wand to get better in 2 visits. It happens occasionally. We've seemed to speed up that time frame to getting better, with the stem cells and peptides. And those are all coming down in price, which is good. But yeah, it's very true. And usually the labs correlate, especially like the inflammatory markers, the C4A, which is a growth factor beta. But if you do a different lab, you get a different result. But so you want to stick to the same lab in general. But, I'd rather have them feeling better and have terrible labs than have great labs and have them feeling terrible. But usually it goes together.
In the overall healing journey that someone with a chronic illness might go through, when is the right time to consider peptide therapies? Is it early? Is it late? When do we generally introduce those? And then are there some things that people should do before they even start introducing peptides, like nutritional changes, detoxification changes? What do we do to set the stage for optimizing these peptides?
Yeah, and that's a very good question. And, it all matters. It all helps. And, all the diet part, really emotional, but the problem is when you wake up every day feeling horrible and you can't do something, you get really, really down. And we find those patients are more difficult to get better. But once they get a glimmer of hope, so we try to get them at least see a good sense of improvement, in a month or 2, so they can have some hope. And you're right, because that is so huge. And they've already, their family, sometimes, some families are great, but other ones, oh yeah, she's sick again. And it's kind of human nature. If someone's sick for more than 2 weeks, like, oh, you're sick, let me help you. Then 2 weeks, and like, just go eat better. Or, the problem is a lot of them look okay. Right. And so it's just the way they lose their friends and, and basically get alienated.
From your perspective, and we talked a little about mast cell activation, but how big of a problem is mast cell activation in something like Lyme disease? And then what do you think are the key triggers of this histamine intolerance and mast cell related issues? And then are there some key things that you do in clinical practice to support that beyond the immune modulation?
Yeah, I think mast cell activation is huge. The standard tests miss it. So we tend to not even do them and almost just assume it's there. But in terms of, so basically the mast cells, usually they go to an area and secrete histamine. So you think of allergic reaction. But what they found with these chronic illnesses, these chronic infections, that they're stimulating the mast cells, they're just pumping out all these inflammatory cytokines, and basically they're not degranulating. So they didn't know, no one knew that they were part of the picture. But, so again, the standard is try to, standard meds for mast cell activation, and we'll do it. We'll put everyone on, Allegra or Allegra D or Singulair, bioflavonoids. But we're really finding thymosin alpha-1, BPC, can be tremendous for that.
And do you think it's the chronic infections that are really triggering the mast cell activation? And if I look at a list of things that can trigger mast cell activation, it's everything from EMFs to heavy metals to viruses to all of the chronic infections. Is there anything that's really kind of come to the top of your list that's the underlying trigger for these reactions?
Yeah, and I think that's the problem. And I think, most people that get Lyme are asymptomatic. If you don't have anything else going on, but all of a sudden, with this toxic world we're in, past the plastics, pesticides, the EMF waves, and then stress, all those things, mold, then that's when all of a sudden it's like, hey, the immune system drops. Now everything just explodes.
Right.
So those are all important.
I want to sidetrack just for a minute into the hypercoagulation conversation. And based on some of what I had looked at your earlier interviews and things getting ready for today, it sounds like there's also a connection between hypercoagulation and mast cell activation. So why do we see so many of these coagulopathies in chronic Lyme disease?
Yeah, so it's called immune activation of coagulation. And I learned this many years ago from Berg. And you look at, like, especially Babesia, but other infections do it as well, where they activate the clotting system. So it lays down fibrin on the vessels, trying to wall off the infection, which, hey, that's good in the short term. But now with this fibrin, oxygen that usually takes 2 seconds to go in the cell can now take up to 2 minutes. So the cells are starving for oxygen. The mitochondria aren't working. Waste products can't get out. Antibiotics can't get in. Nutrients can't get in. And sometimes while people they come in, there are a ton of stuff, and we go, oh, let's treat your hypercoagulability, put them on a little heparin, and also go, everything's working. And now it's interesting if you look at, and I'm on these mastermind mast cell groups, and so I posted, and it was basically a case of a couple cases of people with mast cell flares, giving them heparin and improving it. Now, the dogma is heparin's bad for mast cells. So I can't explain it, but I even, based on the literature, I started taking my patients off heparin and using Lovenox just so, that it's at least could be potentially better, not as bad as heparin, but no one wanted to go off. You don't need to do heparin forever. Once you get rid of it, you may need to cycle back on in 6 months or something. But I think there's a direct effect, and heparin is very immune modulatory. So it has a lot of other effects, a lot of molecules in there that I have no qualms giving it with mast cell. Where I posted that on the mast cell mastermind, I said, you guys can kick me off out of the group after you read this. But it was like, that's interesting. And a couple people said, oh my God, you're right,
Yeah, my observation over the years has been that Babesia in Lyme is definitely one of the key players in these coagulopathies. And so I'm wondering, from a testing perspective, Babesia is still not that easy to test for. So I know there's the ECP, or the eosinophil cationic protein. Is that something that you find seems to match up? If that's elevated, that oftentimes Babesia is playing a role in those patients?
Yeah, I think it's a great marker. It's sensitive with Quest. The LabCorp ones, they're all normal, and they'll tend to be like high normal. That's what we usually see on the initial. Then if you treat for Babesia and then retest, the eosinophil cationic protein goes way up, and that's, you've kind of confirmed the result of that.
Excellent. Let's talk a little about biotoxin illness with a little bit of a focus on the mold and water damage building side, but there's so much overlap here with Lyme as well. So we know in chronic Lyme disease, mold biotoxin illnesses, MSH, or melanocyte-stimulating hormone, is commonly low. Some people will use VIP nasal spray to potentially increase MSH, and sometimes it seems to work, sometimes it doesn't. So I know in the peptide arena, we have things like melanotan-2 and PT141 that can lead to increased tanning, weight loss, those types of things, and can increase MSH. But my question is, when we use those and MSH increases, do we see the symptoms of biotoxin illness falling away like we might expect? or do we not see that?
I haven't been impressed with it.
Okay.
And with those and people, like, especially if they're older and you give them melanotan, like some dark spots come out and they want to kill you. So, but I'm not against BIP, but I don't know. I've tried it so many times and just was not impressed. I'm not saying it doesn't work, something where everything works for somebody. But I've not been impressed with that.
And when you're saying not impressed, are you saying also with the peptides that increase MSH, you haven't been very impressed with those either, or?
No, we haven't really used them because basically, okay, you're going to get tan, you're going to do this. And we give some people PT-141, which is a fragment of that for erectile dysfunction and libido for women as well. But I can't say that I've seen the mold people get better. And really one of the best things is BPC. You take it, it binds up all the neurotoxins, mycotoxins, and heals that leaky gut, which is a huge problem. So we find that is a key for mold.
So that's perfect. That's a good segue into where I wanted to go next. But if we look at chronic Lyme and mold illnesses, there's often these impairments in detoxification. We know toxicity plays a major role in Lyme disease. Do the peptides help our detoxification capacity? So are they helping us from a toxicity perspective as well?
Oh, I think tremendously so. And you look at, really modulating the immune system. You detox a much better when you see, basically BPC will protect against so many toxins, like even alcohol. You can, they blast rats with alcohol. It doesn't affect the liver. With cancer meds, it protects them. It's kind of a homeostatic, basically peptide. So that's one of the key of the detox peptides. And we use other things for it. I love phosphatidylcholine and other things like that, and a lot of IV therapies and ozone. But peptides play a role.
If we look at BPC 157, which is body protection compound for people listening, so many things that it sounds like it's amazing for: wound healing, tendon, ligaments, muscle, tissue injuries, and so on. The nervous system, you mentioned the gut in terms of leaky gut potentially. It can help sometimes with people dealing with pain, improving gut function, resolving leaky gut, irritable bowel, shifting that Th1, Th2 issue that we talked about. Talk to us a little about where does BPC 157 normally occur in the body? How does it work? And then what are some of the things you've seen clinically with your patients? And you gave us one story already, but I'm really curious what you're seeing clinically.
Yeah, so it's naturally in the body and it's stable in the GI tract. And it does get systemic absorption. One study, they looked at the effects on the gut and then also with MS, and orally worked for both. It really lowers inflammation, and they're still elucidating it has multiple effects, but they can't find a toxicity to it. So, one thing, cleaning up the gut is, reducing the inflammation. Also has antimicrobial effects, which is interesting, or it may just be helping the immune system get better. But once you heal that inflammation, those big proteins aren't getting in and not causing the whole cycle of all the toxins getting in. We basically find that that's great. We've seen it work for so many things. We use it as in injections, brain. We can do them nasal. It's unclear right now in terms of what the absorption is. But people do get good results with that. And we'll combine that with the Cmax or C-Lank, which are another neurotropics to build brain. But yeah, as you said, if you read this, there's 100 studies showing almost everything. You sound like, oh, you're a snake oil salesman, because it's like, it helps this, like anything with inflammation or healing, it just dramatically, in protection, it protects the body against toxins, which is huge in Lyme.
So BPC 157 is now available or becoming available orally. It was not previously, other than through compounding pharmacies. So it sounds like you're suggesting that the oral use of this compound does still potentially have systemic health benefits, that it's not limited to just the gut. Am I hearing correctly?
Yes, and that's what the research shows. And we're moving on doing studies on that as well. And yeah, so we brought it out as a supplement, which is much cheaper. Normally it's for 30 tabs, 500 micrograms each, $300, so $600 for 60. For 60 hours is 84, something like that.
Wow. And as I understand BPC 157, because it's having a positive effect on the intestinal hyperpermeability or leaky gut, that should also help some of the mast cell and histamine related symptoms, right? Because now especially if it's food driven, a lot of those particles are not getting through the lining of the gut. And so the immune system can kind of calm down just from that perspective as well, right?
No, that's very true. And we'll give just oral BPC, and some people will go, oh wow, my lupus is so much better, or my Hashimoto's numbers came way down, and because it's like all those things driving it.
Beautiful. You mentioned epitalin earlier, so that's a peptide that potentially is interesting. We talked about it for anti-aging, telomere lengthening. Sometimes I've read for DNA repair as well. When someone's recovering from chronic Lyme disease, you kind of get to a point where you've addressed a lot of those underlying triggers, the microbes, the toxicity, and so on, and then you need to move maybe into a restoration, regeneration, repair strategy. So I'm curious, what are some of the potential benefits of epitalin in those that have had chronic illnesses but now need to repair a lot of the damage of decade or longer illnesses?
Yeah, so the epitalin does a lot of anti-aging. It's probably the ultimate anti-aging, supplement or product. When you look at the studies, increasing longevity. And also, the little trick is we use epitalin, so it increases melatonin to sleep, but has other effects. We use that combined with delta sleep-inducing peptide, which we use those together at night. And that'll work for everyone, but they're like, oh my gosh, I got deep sleep. It doesn't put you to sleep, so it's not like a sleep med, but it takes a couple of weeks, and all of a sudden you're getting deeper sleep. So that's really helped a lot of people. And the delta sleep-inducing peptide actually is very anti-inflammatory in the brain. You can take it throughout the day for inflammation. With what we're using now is even more BPC and sometimes the delta sleep, where the narcotic. Yeah, we have an issue with narcotics, but they're making it so we can't write narcotics unless it's a terminal illness. And these people, they just discount their pain. I don't know who's making these laws, but and our insurance company saying no, if you write opiates, we won't cover it. It's just so one-sided. They just got to fix this problem, and they don't care who they devastate in the meantime.
Is epitalin something that is or will be available orally, or is that one that likely is going to stay an injectable?
We'll see.
Okay, awesome. And do we know with that substance, if we do pre and post telomere length testing, have you clinically seen shifts in that way of exploring it as well?
I've read research that has, and we've done a little bit. We tend not to test that. I think it'd be really interesting for like a wellness clinic or something like that. And we treat, wellness people, or mostly hormones. People generally don't come in for just, hey, I'm well, I want to keep well. We don't have, unfortunately, I'm jealous of people that have those patients, but we really don't see those. So I tested a couple times on myself, and mine went up, but I can't say that's an N of one.
Right.
That we've seen it consistently.
Let's talk a little bit about autism. So we're talking now about 1 in 40 children, depending on what numbers you look at, that are potentially impacted by autism. Is there a role for peptide therapies in dealing with children with autism?
Absolutely, absolutely. And you look at autism, what is the cause? Multifactorial, but what is the underlying problem? It's immune dysfunction while the baby's in utero. For instance, the big controversy over vaccines. Vaccines definitely contribute to autism because they raise that Th2, basically with these early immune system. Now it just sets everything off. They have that low Th1, Th2. They get all the inflammation and so many problems. We've had people come in with totally fine, got the flu shot, and they're just 2 weeks later, they're like, I'm in bed and haven't gotten out, and basically they got chronic fatigue now. And I've sent letters to the FDA. Of course, they go, no association. But in particular people, especially these other things going on, vaccines are a problem. So with the autistic kids, you can look at a number of things. I like Pitocin for them, which basically is the bonding hormone, also immune modulator.
So for people listening, that's the same as oxytocin, right?
Yes,
yeah.
Yes.
Okay.
And just a little side note for anyone who's on IVIG, add 10 units of oxytocin, Pitocin to the bag or separate. It will work probably 2 to 3 times as well. There's no studies on it. It's just we have found it consistently. Just a little side note. But with autistic kids, the Cmax and C-Lank are wonderful. The epitalion, thymosin beta-4, again, repairs brain. And then we found the stem cells and exosomes are the combination. We usually get them on the peptides first and then do the stem cells. And we've seen wonderful, just heart-wrenching improvements where one child who's been coming for quite a while, mom gave a video of him playing basketball, and she gives a video, it's the basketball going by, doesn't even look at it. Now he's like playing basketball, he wouldn't really interact with people, he's telling jokes, he's being sarcastic, you couldn't touch him, he would just throw the F-bombs around, if we tried to touch him. Now he's like, can I have a shot? Oh, how are you? Telling jokes, can I have a hug? And it's just
huge.
What a difference,
I mean, it's very sad and difficult to work with these chronic conditions, but I can tell that, you're making a big difference in a lot of lives. And I can tell that you still love every bit of what you're doing and being able to use a lot of these tools to help people. So, I mean, your passion for what you're doing really comes through very clearly. Let's talk about in neurological diseases. We know neuroinflammation is a hallmark, but there's often also these myelin associated issues that can be a factor in something like multiple sclerosis, maybe in some symptoms that people deal with Lyme, like tinnitus, for example. Do the peptides have a role in healing the nervous system and or helping to support the production of myelin?
Yeah, and you look at the research on thymosin beta-4 showed increased myelin, BPC as well. So very healing, but we usually combine with stem cells or exosomes. And we've got very good results. And like the neurodegenerative diseases with, there's an infection going on in there. These Parkinson's people, it's an ALS. My gosh, that's Lyme till proven otherwise. Like Michael J. Fox, we called him and said, look, let us help you. We said, does he check for Lyme? Oh yeah, he had it, but he got treated for it.
Yeah.
So, and you look at the autistic kids, they often have white and gray, or Lyme patients as well, non-specific, white matter changes. So they lose the myelin, but they go, oh, it's normal, nothing, it's not abnormal enough to be a problem.
So you mentioned ALS. Are you seeing that if you deal with the underlying chronic infections and then maybe use the peptides and stem cell therapies, are we getting close to a point where we have some repeatable solutions for people that struggle with ALS?
Yeah, and again, ALS, Lyme, or some other infection until proven otherwise. We've had patients come in a wheelchair and they're jogging. Can't guarantee that. Not saying that we have a cure, but kind of a multi-system treatment for that is key.
You've talked about the synergy between peptides and some of the stem cell therapies. With the stem cells, are you now starting to use exosomes? And maybe you can, for people listening, talk to us just a little about what are exosomes, how are they different from stem cells, and then what is the synergy between these and the peptides?
Sure. So basically we thought in the olden days, which, things moving very quickly, that you give a stem cell, it's going to go to that area that has damage, and it's going to regrow and change into that tissue. That doesn't happen. It secretes cytokines, peptides, growth factors to stimulate that area to basically repair itself. And it will activate the stem cells that are they're dormant in that area. And so the exosomes, and what we found too, is that they don't just secrete growth factors. So if you do that, they're just in the blood and they get eliminated very quickly. But they'll bud off, so think of a lipid cell, they'll do little buds of lipids that have in there peptides, growth factors, a lot of times LL37, antimicrobial peptides, as well as mRNA, DNA, especially mitochondrial mRNA and DNA. And the exosomes, so they're much more protected. They can go through the body and then attach to where they're supposed to go. And then when they attach, they dump the contents right into the cell. So it's kind of a special delivery system that's a smart delivery system.
You work with a lot of patients that are very sensitive, that have either multiple chemical sensitivities or mast cell related issues. Do we generally find that the peptides are fairly well tolerated in that sensitive patient population?
And it is. It will help the sensitivity. Mm-hmm. Now, I can say I have a couple patients who are so sensitive. I mean, they're intolerant to everything. So any little change seems to affect. But in general, even the sensitive patients can tolerate those. And with like stem cells, you'll see some people crash with the stem cells. Now, one is especially with the adipose, because there's so much inflammation of mast cells and adipose. You're just giving that to the patient. But there is also can be a flare with umbilical tissue, umbilical cord. So we like to do in the peptides actually stimulate the stem cells. So thymosin beta 4, BPC, they tell those to grow and still basically get going. And in return, the stem cells secrete those peptides. So it's very interesting. But we try to get their immune system somewhat regulated first, and then especially if they're prone to being sensitive, then we want to watch out and not try to send them downhill. Although a lot of patients, if they crash, they're much better after 6 months than they were.
Yeah, and that's been my observation with stem cell therapies as well. I seem to observe that if people do stem cells early on, before they've started detoxifying, before they've started doing immune modulation, before they've dealt with some of their intracellular pathogen burden, that the results are not always what they hoped for. But if they do some of these early things and then bring the stem cells in towards the later part of treatment to regenerate and repair, then it seems like the kind of later in treatment is where people maybe have some better potential effects from them. Is that similar to what you see?
Yeah, I'll totally agree with that. But also we find that if we do it earlier, you can fix a lot of the problems and you get better. So it's kind of a continuum and patient by patient. Yep. But I totally agree with both points of view on that.
Okay. And then when we have peptides that are, let's say, stimulating the production of growth hormone or other hormones and things in the body, are they essentially modulators, or can we overshoot the mark and that we have to still be observant of what the levels are and kind of titrating dosages and things like that?
Yeah, in general, for instance, the growth hormone secretagogues, growth hormone releasing peptide, growth releasing hormone, they will stop working. They won't overshoot. They're basically like giving more twice as much does not give you twice as much. So it's very difficult to overdose on those because you'll stay in the normal range.
When someone's on, let's say, a protocol that's incorporating peptides, my understanding is that they can be on several different peptides. Talk to us a little about how they're generally delivered into the body, the different ways of administering them. My understanding is that there's multiple options there.
There is, and we're coming up with more, but we just want to validate the absorption and everything. But in general, we'll start people on BPC orally. And then most of the other peptides are given subcutaneously. Now, a little controversy in this, but you give the vials and then you just pull up each one. So you're not doing a ton of shots, just mix them together and give a shot. We will do some nasal, but I can't guarantee the absorption, but clinically we've had very good results. And also we're doing like exosomes, where stem cells probably too big to cross, like up in the nasal mucosa, but we're putting exosomes right in the sphenopalatine ganglia with a little catheter, and which are much smaller. They're tiny, and can get right into basically they go up the nerve and get right into the brain. So we seem to be having some good results with that.
So with all the things we've talked about with peptides, if you could only pick 3 peptides to have with you on a desert island.
Oh, no, I can't do that.
Are there some of them that really have clinically for your patients risen to the top of your list?
I would say definitely thymosin alpha 1, BPC, and would depend on what other condition. Could be TV4, but you got those covered. Epitalion, probably. Maybe for brain, Cmax. So,
and we didn't really get into a lot of the brain, the nootropics, but that's exciting as well with the peptides, because it sounds like for people that have traumatic brain injuries from concussions, maybe even strokes and other things where there haven't been lots of options available to really help in those scenarios, that the peptides also potentially are helpful with those types of conditions as well, correct?
Yeah, we're doing pre and post SPECT scans to show. So that should be exciting news coming up soon.
Beautiful. If someone's listening to this podcast and they're really interested, either a practitioner or potentially a patient, how do they find somebody who uses peptide therapies? How do they learn more about it? And then are there some trusted sources for how they access these tools? Because I know you can go online, you can find these things. I personally wouldn't want to be injecting something that came from a source that I had no idea what that was. So how do we make sure we do this in a way that's
and some of the online places, if they come from China, in the manufacturing process, there's basically a substance that if they don't remove it, it's slightly carcinogenic. But who wants even slightly carcinogenic? Mm-hmm. And fake stuff, and who knows what it is. So probably the biggest supplier of peptides currently is Tailor Made Pharmacy, mm-hmm. and then there's other ones, Absolute, and a variety of them. And then there's the International Peptide Society, which has a lot of great information. And we had a lot of great information on our nonprofit site, National Academy of Hypothyroidism, and our Holtorf Med site. But because we have a product out, we're trying not to violate any rules of advertising. So it's interesting, like, we can't put a study up. I said, no, you have a product, so it's strange. But
right.
Those are generally the ones that are selling the most and reputable.
So the peptides are pharmaceutical items that need a doctor to prescribe, correct?
Correct. Except for the BPC, now it's a supplement.
Okay, beautiful. This is a question I ask everybody. What are some of the key things that you personally do on a daily basis in support of your own health?
Well, that's, I tend to experiment on myself too. When I'm feeling good, I'll try something weird. The staff is, here. I'm usually at the office till 11 or 2 a.m. and they leave. I always got IVs in me or doing weird stuff. But I really think the core are peptides, and keep the immune system up. I think doing some ozone a number of times a month is key. Eating well. I can't say I do that very well with my Starburst breakfast, but so I don't counsel people on diet too much or exercise. I'm actually religiously exercise 12 minutes every 3 months. So, so it's my passion, right? So I give people leeway on that, but and then I think the stem cells. Maybe every 3-4 months I'll do some stem cells or exosomes, and that's kept me healthy, and thank God. And I want to just tell everyone, the listeners with Lyme, and no one knows how bad you feel. It's like, it's unexplainable. It's horrible. And the way that they're treated, and no one believes it, but it's like, oh my God. But there is hope. There is hope.
Absolutely agree. This has been a super fun conversation, very enlightening for me. This was a topic that I had just started hearing about several months ago. And so having the opportunity to hear all of this from you has been fantastic. It's nice that we have some new tools now, potentially in the realm of Lyme and chronic fatigue and immune modulation. So I'm really excited about everything that you shared with us today. And I just appreciate people like you that are out there continuing to look for new solutions, look outside the box, and to try to find things to help people really improve their lives and minimize their struggle. So thank you so much for everything you do, Dr. Holtorf.
Hey, I could say the exact same thing for you. So thank you for having me, and I appreciate your work.
Thank you. Be well. To learn more about today's guest, visit holtorfmed.com. That's holtorfmed.com. Thanks for your interest in today's show. If you'd like to follow me on Facebook or Twitter, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. If you'd like to be added to my newsletter, visit betterhealthguy.com/newsletters. And this and other shows can be found on YouTube, iTunes, Google Play, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.